Have y'all seen Cinderella Man? That's a great movie. Then we needed one. Maybe we needed 5 Rockies to get it right. 6, and I say 5 because Rocky 5 doesn't really exist. My kids will plant a flag on that hill. They're like, Rocky 5 doesn't exist. Y'all seen $1 Million Baby?
Oh, yeah.
Yeah, Clint Eastwood figured out writing movies and directing movies. That's a great movie. No, the Rocky anthology is probably the favorite in our house. We love Rocky. And we figured out that Rocky's not an action movie. There's action in it. Rocky's a love story. Y'all ever seen Rocky Love Adrian? You go ahead, make fun of him. Rocky's pretty good too. All right.
Napoleon Dynamite. Sure, not Napoleon Dynamite.
I figured we would get a little more conversation with this one. So the actor for Napoleon Dynamite, the main actor, John Peter, I think his name is. Y'all seen his TikTok? Apparently he got like no money for that movie. No royalties coming in, nothing. I don't know if it was just bad business or they rope-a-doped him or what. So now he's like trying to relive his glory days and his kind of like niche acting style. It's really hard to watch. But
Mean Girls.
My wife.
Why so fast?
I love how the men have the first opinion on this, right? That's awesome.
I lose a guy in 10 days.
I'm a sucker for Mean Girls. It's pretty quotable. The amount of times I have said from the back of some stadium somewhere, he doesn't even know it. So I found out that if on October 3rd, if you start Mean Girls at 10:59 p.m., at midnight you will hear somebody say, it's October 4th. You guys remember from the movie? Hey, what day is it? It's October. Most important one. Easily most important one.
I see.
All right, let's see how well you know it. What is the name of the chickmunk that's always chasing the acorn? And over the hedge, what's the name of the hedge? Anyone remember? Steve. Let's call it Steve. I'm much less scared of Steve. And then Secret Life of Pets, Guilty Pleasure, because I like listening to Taylor Swift sing theme song. I usually put it on as I'm going to bed and I last about 5 minutes before I'm out. But Secret Life of Pets has a dachshund in it, and dachshunds are easily the best animals in the whole world. Do you guys know why they have so many dachshunds, wiener dogs, in Western movies? Because the cowboy said to get along, little doggy. All right. There's our introduction. That's the best I got for you. I'm sorry, guys. All right, I am a primary care PA. I am not an infectious disease specialist. However, just by mere walking through life as a medical provider, you will run into infectious disease a lot. So some good understanding of it and some good ability to kind of tease out what might be happening. Treat it, of course, is value added. So we will not treat this from an infectious disease specialist perspective. We're going to treat this as infectious disease from a primary care standpoint. Still going to be a challenging course. There's still a lot to kind of learn and the treatments for it. My goal is to get to a place where we are done with our lectures with one lecture block remaining. I like to use that last lecture block as an opportunity to catch up on anything maybe we didn't hit well enough or there's questions on. Maybe even give you guys a chance to practice a couple test questions, get yourself a vector check before the test itself. The way that I do, if we can get to there, the way that I do my last lecture block in that scenario is, if you guys aren't kind of familiar with the material, it may not be super valued. Because I'm not going to come in here and just say, here's 50 questions, 50 points, make sure you know these and you'll be fine. There is going to be some kind of practice test questions and some review, but if you guys don't have some studying already in the books for you, you may not know the weak spots in your own knowledge path. So I do recommend kind of following along, learning as you go, and I am very aware that the junior semester is the crucible. It is the toughest semester in IPAP, in my opinion. If you get through the junior semester, I'm not saying that you're guaranteed to pass, but you are at the peak of your ability to learn, test, and so much of the other stuff tends to start to come a little bit more naturally because you've honed your skills as a studier, test taker, etc. So I know you're in the middle of it. We'll get through this at the best of our ability. So fever of unknown origin is the first topic that we're going to talk about. And just like it kind of implies, there's a fever going on in a patient. We do not know what's causing the fever. So our job is to do our best to kind of figure it out. Now, if you're anything like me, you probably have a little bit of a smart aleck brain inside. And you say, well, every fever is technically of unknown origin until you figure out the origin. True. But this is a diagnosis that won't go on to a patient until they've started evaluating for the fever's cause and have run into just roadblocks in figuring out what's actually causing the fever. All right, so definition that we will use is a condition where a patient has a prolonged fever without an identifiable cause despite evaluation of it. Understanding this is crucial for effective diagnosis and treatment. That's understandable. We gotta kind of know where we sit and fit. There are 4 categories: classic, healthcare associated, immune deficient, and HIV related. You guys remember the word that kind of describes that healthcare related scenario? Nosocomial. Excellent. Nosocomial. All right, classic fever of unknown origin. So recognize it says 38.3 degrees Celsius or 100.9 degrees Fahrenheit. What is the normal cutoff for what we're calling a fever? 100.4. Recognize that this is a different temperature. Remember, this is kind of its own diagnosis, if you will. So they've actually gone ahead and said, hey, because this is a little bit more unrecognized etiology of causing the fever for this patient, a little bit more serious, we can't figure it out, let's set the standard a little bit more strict so that we can actually go ahead and follow it through. So a fever of 100.9 or greater, and then you can see this is still the classic scenario, duration of the fever for at least 3 weeks, 3 outpatient visits, or after 3 days in the hospital with no identified cause. So a lot of times, and you'll get very good at this, you'll have a patient with certain symptoms, and if there's an associated fever, we can usually pare down to what it probably is at that point. So for example, if you have a 16-year-old patient with white exudates on their pharynx, large tender cervical lymphadenopathy, a fever, and they are not coughing, what is the most likely diagnosis? Strep. We just went 4 for 4 on the Centaur criteria, so we don't have to call it fever of unknown origin. We have a really good idea of what that fever is caused by. We treat the causative agent, patient gets better, which is excellent. So in this case, we are actively looking for a reason for this fever, and we are not able to find it. All right, second category, healthcare associated or nosocomial. This is a situation in which a patient has a fever after a couple of days in the hospital, 3 days in the hospital at least, and that fever was not present on the admission. So somebody came to the hospital for a different reason, fever was not there or the cause was not there, and they developed the fever, and now they are looking for the reason for the fever and they cannot find it. Then you have immune deficient or neutropenic fever of unknown origin. In other words, you do a CBC, you realize that their neutrophil count is lower than it should be. And so we have somebody who is in an immune deficient state. And so it is easier for symptoms to present that otherwise may not be as robust. Now we have a fever. And then we have HIV related. HIV, recognize it says 4 weeks durations. Greater than 3 days is inpatient. Remains unclear. We're going to talk about HIV here in a minute. An HIV patient, especially if they're a little bit farther down the path, moving towards that AIDS situation, are just going to be more susceptible to opportunistic infections. And when those infections happen, they hit the body a little bit harder and last a little bit longer. So in this case, they've increased the time frame from 3 weeks to 4 weeks, because if that HIV patient needs a little bit longer for their immune system and or interventions to kick out the reason for the fever, and it's still present, then we might have a more significant underlying pathology. Something I read that I thought was very interesting was most of the times when you have fever of unknown origin, it is an atypical presentation of a common disease, not a common presentation of an atypical disease. Have you guys heard the phrase zebras? Like if we say we're looking for a zebra, that's familiar to you. Okay, perfect. We all want to find a zebra. It's super cool to find a zebra. You write it up, get published for it, all that good stuff. In this case, when we have fever of unknown origin, we commonly have an atypical presentation of a common disease, not the other way around. I found a couple zebras along the way. They're pretty cool. All right, so 4 categories of fever of unknown origin. Here is a list of examples of evaluations that we can include in our or things we include in our evaluation of the patient. This is not an all-encompassing list. This is an example, a good example of things that we should start to ask questions about, evaluate in our patient's status and history, to help figure out where this fever is coming from. And if you were to look at all of those things up there, I'm not going to read them verbatim for you. That tends to make sense, right? Can we get an idea of what's going on with the patient's personal history, travel history, exposure history, see if we can kind of start to pare down to where this fever might be coming from. All right, some classifications of these causes: infection, malignancy, there's a miscellaneous there, autoimmune, and undiagnosed. Big red box square to the top corner says most common. You guys know if you see something that says most common, it's probably a good idea to just go ahead and throw it in the memory bank, right? People love to ask questions about most common. That's not a thing for this course. I mean, it is because it's a thing. It's all over the board, right? And even when you take your pants, very, very common to have questions about most common things. So I have found that the most common questions are from the most common things. So I always just like, yeah, let's just memorize it. One of the things that kind of sticks out to me, and I had to walk through it as a PA the first time, was if you look in that miscellaneous tab, it talks about a drug fever. Do you guys remember any drugs that can cause fevers? What's that? There is a really common one. You may not even have been taught it, which is totally fine. You know, non-steroidal anti-inflammatory drugs can cause fever of unknown origin. Yeah, it's just a reaction from the body. Obviously, it's not super common. NSAIDs or ibuprofen is all over the place. You get it over the counter. We prescribe it all the time. We may have taken it ourselves a lot, and it's not super common. But there are some other ones. There's some antipsychotics and some old school antidepressants that are kind of known for, and anticonvulsants that are kind of known for causing this. So all that kind of says, because it goes back into, hey, a good history of the patient, all the things about them can help us a lot when we're kind of looking for what the fever is. Do you guys remember a type of medication from your psychiatric class that creates a syndrome that can come with the fever? I know, that's like, I hate this game, right? What am I thinking? It's such a terrible game. Yeah, serotonin syndrome. Serotonin syndrome. So serotonin modulators, SSRIs, SNRIs, are very common medications to get prescribed as well. And so that serotonin syndrome also comes with a fever. So there's just lots of things out there that can cause this. It's not always an infection. Infection's pretty common. But when we start to get to this point of, like, man, this person's got a fever, having a hard time kind of figuring it out, the infection etiology is not obvious, we may start to look at some other scenarios. I had a patient once who was reporting fevers, nuchal rigidity, photophobia, and phonophobia. Does that sound like anything to you guys yet? Meningitis, yeah, meningitis. And I went all the way through her history. I was like, man, it walks like meningitis, talks like meningitis. But like this patient's sitting in front of me, and she wasn't febrile. She was a little higher temperature, but not febrile. And did a history, and we had started her on Bactrim for a cellulitis. And so research found that Bactrim, or trimethoprim sulfamethoxazole, is another common causative agent of a drug-related fever. And in this case, aseptic meningitis also happened. And so, yeah, kind of one of those really weird, interesting things. So good history is really, really paramount to helping us kind of figure out the cause of the fever. Here are some examples of what could be causing it. This is, again, not an all-inclusive list. I'm going to let you also in on something. I am taking over this class from a former colleague who is moving out of IPAP. Totally fine. Very normal thing to happen. IPAP kind of way of life is when somebody new takes over a course, they tend to kind of roll with the slides. So I didn't write these. That's not punting some type of responsibility somewhere else. What I'm getting at is don't think that these are up here because these are super important to me so that you can be tested on. This is just kind of a snapshot of what to look at, some really common things that can cause this fever, okay? I probably would have laid it out scooch different, but it doesn't change anything. Really, really common things to cause these fevers. All right, some lab tests that we would want to do. Blood cultures can be really important. If we're going to do blood cultures, it's recommended that we do at least 3 of them, 30 minutes apart, and from different areas of the body. We ought to do the blood cultures before somebody has started antibiotics, if possible. Sometimes people will be on antibiotics, maybe they're treated empirically for something, and the fever's not going away. May not get that all the way. Culture, we can culture just about anything. And again, at this point, remember, we are looking for something different that's out of the ordinary because it's of unknown origin. So we can culture just about anything. If you are going to do a blood culture, other cultures, it's recommended to give it a pretty long time to grow out because there's some organisms that just don't grow out super quick. And so, and obviously, if we find a reason for it, we don't have to follow this, but it can take up to 2 weeks for some organisms to grow out. A CBC can give us some signs of infections. We can look at the neutrophil, lymphocyte, and eosinophil count, see if that gives us any hints to what might be causing the fever. And some liver function tests can give us some indication if there's any liver involvement, which again could point us to part of the diagnosis. LDH or lactate dehydrogenase, it's a compound that is secreted when there is tissue death. And so if we see a positive LDH, we can ask ourselves, all right, can we figure out what tissue is dying, which could give us a reason or a potential place for where the infection's at. ANA, do they still do clin lab? So you've heard a lot of these already. So ANA, anti-nuclear antibody. It doesn't tell us what autoimmune disease, but if you have a positive ANA, it could be a sign of an autoimmune disease, which could be causing the fever. Your comprehensive metabolic panel, your CMP, gives you a lot of electrolyte balances, and some of those being high or low can point to some specific metabolic abnormalities, neoplastic abnormalities, or could be signs of an infection as well. A TB test, if it's positive, could be a sign of tuberculosis, active tuberculosis. And then the CRP and the ESR are inflammatory markers. If those are elevated, it's kind of just telling us that there is inflammation in the body. It doesn't really tell us where that inflammation is in the body. There's kind of a joke in the hospital. You guys know what a positive ESR tells you? It tells you that the lab is open. All right, if we get to this place where we have a fever of unknown origin, we don't know what's going on, everybody gets a chest x-ray. Everybody gets a chest x-ray. We're looking for something that could be going on. And then we could do further imaging based on kind of what we see from there or what the symptoms are. We wouldn't necessarily throw imaging at every part of the body right away, but it is well within our ability to order stuff as we see fit to look for the cause of this origin. Or the cause of this fever. Some procedures that can help us in our diagnostic path, all kinds of stuff. Cerebrospinal fluid analysis, lymph node aspirates, biopsies, bone marrow aspirates. Us as primary care PAs probably are not doing a lot of these, probably especially not early, just kind of knowing that these are possible evaluation tools are good to know. All right, let's talk about managing the patient with the fever of unknown origin. That one bullet there says stop all the meds for the first 72 hours. Any idea why that might be there? See, it sounds weird, right? Why would we stop medications? It could be medication induced. You know, if they're on a lot of medicines or a lot of new medicines or recently adjusted to medicines, it may not tell us which medicine caused it, but at that point we kind of just need to stop the fever because there could be some potential damage going to the central nervous system if that fever is prolonged. So we can stop them. If we want to use an antipyretic, if the fever is high enough that we need to control that fever, you can kind of make the decision in the moment if that's value added for that patient or not. But ideally, if we're trying to manage this, get them off some medicines to see if that gives us a clue as to what's going on as well. Avoid glucocorticoids and empiric antibiotics. Again, we don't overtly know what's going on, and these are recommendations. Some treatment, remember that first one's management, kind of that initial management where we finally, okay, we can't find the source, Now we've kind of gone to the next step. We're calling it fever of unknown origin. We're in this kind of like ship at sea scenario where we're looking for what could be there, could be the cause, haven't figured it out yet. So we're managing the patient early on. Some treatment options once we're a little farther down the road. Empiric antibiotics are not a bad option if you're pretty confident there's a infectious etiology. Some broad spectrum antibiotics have shown to be pretty decent. Antibiotics also have a really strong anti-inflammatory effect. They're not necessarily steroids, but they do take down a lot of inflammation in the body as well. So they can simply just help the patient feel better as well. Behavioral health. Any idea why they may have thrown behavioral health in here as a possible treatment? What's that? You're spot on. Obviously, psychiatric conditions shouldn't cause a fever, right? But we're in a situation where we have this like objective evidence. We have thermometers that say we've got a certain temperature, we're calling it a fever. There are ways to fake fevers. If you're going to do an oral thermometer, maybe you drink, somebody drinks coffee, it's a hot beverage, something like that first. Or they lie about it. Maybe they come in and say, I've had all these fevers at home. So malingering is a word that is used a little bit more commonplace. Do you guys remember the more formal DSM criteria word for malingering? So yeah, it starts with an F, ends in factitious. Yeah, factitious disorder. So factitious, they're lying. Yeah, they're not lying for any perceived secondary gain. There is another condition, malingering, lying for the purpose of secondary gain. Is there another similar condition where maybe it's not the patient doing it, but somebody else doing it? So we call it Munchausen's or Munchausen's by proxy. The DSM calls it factitious disorder imposed on another. So think of a caregiver forcing somebody to feel hot or faking the temperatures because they get some type of maybe attention out of it or whatever. So it's not automatic that you have to send them to behavioral health, but it is not wrong to consider the need to kind of help with that psychological state of the patient. And of course, apologies. Ideally, figuring out the underlying cause will help us significantly in this patient. So there's a brief conversation on fever of unknown origin, 4 classifications. When we have those classifications, it can kind of help point us in a certain direction. Talk about some evaluation tools, some management, and some treatment options. Any questions? That's easy, right? We have a fever. We don't know where it came from. Let's figure it out. All right. Are we okay to move into the next lecture for a little bit? You guys doing okay? Am I the last lecturer for the day?
No.
Sorry, yes.
For lunch. For lunch. Just because of the time.
All right. Human immunodeficiency virus. We're going to have a lecture on this. Remember there were 2 subcategories in fever of unknown origin, immune deficient and HIV related. So the big difference is one of them is a person that's positive for HIV. The other is a person who has an immune compromise, non-HIV related. And even that immune compromise can be iatrogenic, meaning imposed by medications for like autoimmune disease or something of that nature. So we're going to have a conversation here about human immunodeficiency virus. There are perspectives on this disease from all different walks of life, backgrounds, etc. What I realized early on was the more that I'm familiar with it, the less, I don't say scared, but the less nervous I am to, one, have the conversation, evaluate for it, but also in healthcare, there's also an exposure risk specifically. That's there as well. I have treated patients with HIV out of my primary care clinic, and I have done pre-exposure prophylaxis with patients who live a lifestyle that was a little higher risk for contracting HIV. And so there's some experience there. In my most recent role at the psychiatric hospital, we do a lot of substance abuse and detox, and so many, unfortunately, IV drug users, the HIV prevalence is pretty high in that population as well. So seen it quite a bit. It's a heartbreaking condition to watch slowly deteriorate the human body, but it is out there. The more that we know about it, we can evaluate for it, have our differential appropriately, and go from there. Let's talk about the differential for a minute. When I say differential diagnosis, what comes to mind? I know, it's a long answer, not one word, hard to answer. I love that thought process, right? So, too many times, especially through like ClinCore, when you start that and such, we will get to the end of a virtual or synthesized patient encounter, and we'll say, what's your differential? And it feels like we just have to take this moment and throw in 2 or 3 extra things to say it could have been this. If I was to offer a piece of advice to you, and this is not just for this class or ClinCore, this is for the rest of your career, put that differential diagnosis skill set at the very beginning of your patient encounter, and it will significantly help you, right? So the whole point of a differential diagnosis is to help you know what to think, see, look for, ask about, right? So if I say you have a 21-year-old male with painful urination, there's probably a handful of things that come to your brain right away. It says it could be these things. So we ask questions to rule in or rule out, do exams, lab tests, etc. So the more comfortable we can have with that differential diagnosis building and evolution when we're in patient care, it helps us get to the end and be like, I have a really good idea of what's going on, or at least a good idea of how I want to treat this patient. Help us. When it comes to HIV, HIV falls into what they call one of the great mimickers. Have you guys heard that phrase yet as well? There's a handful of conditions, they kind of call them the great mimickers. In other words, this thing can look like anything else. So it's kind of always on the differential. And of course, you can kind of lower that differential priority after talking to the patient or whatever. You guys remember anything else that's on the great mimicker differential? HIV, syphilis, lupus. Those 3 tend to be the 3 great mimickers. So part of that is me saying, when you're in phase 2 and you're like, man, I have no idea what's going on with that patient, and your preceptor's like, what's your differential? You can be like, HIV, syphilis, lupus. And they're like, well, you're not wrong. You guys ever see Avengers, the movie Avengers? Remember when the one guy is like, he's not wrong, he's just inappropriate? Like, you're not wrong. When you're in phase 2 and you're precepting, there's a couple of ways to get out of questions. My personal favorite was the muffin method. You just carry a muffin with you. You'll never eat it. And as soon as somebody looks you in the eyeballs and you see them starting to ask a question, you take a bite of that muffin. They will be so put off by waiting for you to finish the bite of that muffin. The chance of them moving to somebody else with their question is better than them waiting for you to be done. So, when you're in phase 2 and you're like, man, I got surgery rotation, banana nut muffins, man, let's stay for the day. All right. Human immunodeficiency virus, it does fall into that kind of great mimicker category. We'll talk about it. We'll talk about the steps of it. But please know that this condition, it gets inside the human body, inside the human immune system, and it completely erodes it from the inside out, and the body kind of just falls apart from the inside. It's really quite heartbreaking to watch it do its thing. Here's how I like to run class. I don't do checks on learning at the end of class. I find it relatively inefficient for me to give a lecture to you that potentially you've never even heard this material before and immediately ask you to remember everything. That seems a little unfair. So I tend to try to start the beginning of class with some stuff that we've already learned in past lectures after you've had a chance to digest it, think about it if you choose to, and then offer a second layering of some of that information to remind us of kind of where we're at and where we need to be. So there was some pre-reading assigned. If you've got a chance to get it done, we'll just kind of use that as some stuff from the past to give you an idea of how the rhythm of class will go. Yep. So here's how I like to use some of these questions. These are not exact test questions. They're written in the style of test questions that'll come from one of my tests. So you can kind of get the idea of what to expect on your test. Obviously, these will not be on your test, but if you use these test questions as kind of a vector check, you should have a good idea of whether you're making good efforts to understand the material to the depth you need to understand. Okay? So this came out of the reading simple definition. Anybody know what it is? Echo, virulence. And so just simply the ability for something to cause a disease. I learned in my own study a long time ago that if I could make something really corny, really stupid, I'd probably remember it better. Like I mean, you saw my movie choices, right? Like I kind of like some of the slapstick stuff. So I kind of said virulence sounds a lot like violence. So the virulence or violence of a disease is the more likelihood it can cause a disease. So virulence. And we'll talk about viral load of HIV here. This came out of the pre-reading we gave you, and just an example of where it came out of and how to digest that material as you're learning it to help answer your questions. Anybody want to take a stab? Delta. Empirically treat. So I ran into this a lot of times working with students in previous clin course sessions. We don't always have this best understanding of what empirical treatment means. Somebody says, I'm going to treat empirically, or you should go treat empirically. What does that even mean to go do that? And so I brought this question one because it's important here, but there are a lot of stuff, especially with infectious diseases, that we do treat empirically. So empirically just kind of says, I'm not going to go do more of the quote-unquote tests to prove what I think it is, but statistically speaking, patient presentation speaking, the possibility of this being what I think it is so high, I'm just going to go ahead and treat it. So I'm treating it based on clinical experience, statistical evidence, and likelihood. That's why I'm treating it. That's an empirical treatment. So here's kind of the definition for it. I'll give you a minute to read it just so you can kind of see where that is coming from. I appreciate the example about the malaria treatment that this paragraph gives. But let's go back to the patient presentation we kind of made up earlier today. You got a patient, they're 4 out of 4 centaur type criteria. Would you agree that's pretty high likelihood that's group A beta hemolytic strep? Safe to treat that patient? Agreed. Obviously, we would check for allergies, stuff like that. That's an example of empiric treatment. We have this patient, we've seen it a lot, it meets a preset centaur criteria that's been well vetted. We're empirically treating that individual with an antibiotic instead of doing a culture to see if group A beta hemolytic strep actually grows out. Out of curiosity, do you know why you would not do a rapid strep test if you had 4 out of 4 centaur criteria? What's that? Any idea why you might not do a rapid strep test if you had a 4 out of 4 centaur criteria? So here's a way to answer this question all the time. Because in phase 2, you're going to be asked, why? Why do you want to do that? It's a very good question. It teases your knowledge, grows your understanding of what you're doing, and your confidence. The reason is almost always because it would or wouldn't change my treatment plan. So if you have a patient with 4 out of 4 centaur criteria, are you treating them empirically? I am. Right? So if you got a negative centaur or negative rapid strep, would you all of a sudden not treat them? Probably not. I would still treat them, right? What if you had a positive centaur or positive rapid strep? I'm already treating them. So it wouldn't change what I was going to do. However, if you had 4 out of 4 centaur criteria, is it reasonable to do a throat culture? Why? No, no, I just told you what the answer is. It would change what I would do. So let's say we gave them a beta-lactamase inhibitor, penicillin, right? You grew out the culture, did a sensitivity, and it wasn't sensitive to a beta-lactamase inhibitor. It was resistant. But the sensitivity said, this drug, it is susceptible to. It would now change what you would do. So, good job. You were spot on the right path, right? And so it would or wouldn't change what we would do. Why would you do a CT, X-ray, this thing or that thing? It may or may not change what I would do. Almost always a good answer. I'm not just giving you the answer so that you can be right in the moment, but it's a great way to view why you may do something, right? How would that alter what I would or wouldn't do? So that is an example of empiric antibiotic or empiric treatment. Why did you guys say specificity? Who taught you that? So ChatGPT taught me the other thing from what you just said. So sensitivity is the test can be described as a proportion of true positives. So specificity gives you true negatives. Ideally, a lab test would give us both, right? High sensitivity and high specificity. I could trust the positives and the negatives. Unfortunately, we don't always get that in the world. We get to choose one or the other, and so a lot of tests will either come with high sensitivity, meaning if it says it's negative, we can trust that it's negative. Or high specificity, which means, I said that backwards, sensitivity is high if it's true, we can trust that it is. If it's high specificity and says it's negative, we can trust that that is. So sensitivity is the ability for you to get true positives. Specificity is the ability for you to get true negatives. Which one do you think would make a better screening test? High specificity or sensitivity? You want the one that gives you true negatives. They tend to be a little bit quicker and easier. So if I want to know whether somebody has flu A or not, I want a test that's quick and simple. So if there's a test that gives me high specificity and it says no, I can trust that it's no. Those tend to be used for screeners. They're usually a little bit quicker. If I need to confirm a diagnosis, I might use something that has high sensitivity so that I can trust that it is a true positive. So let's say I do a flu A screening test and I get a positive result. But if that test, I'm not saying that it does, I'm saying if that test has a low sensitivity, I may not be able to trust that that positive is a true positive. So I might go to a confirmatory test with high specificity to confirm that the positive is positive. So, for some reason, my brain also said what you said originally, but I looked it up in Current, ChatGPT, and in a lot of other places. And sensitivity is true positive, specificity is true negatives. Did they go over that in Clinton Lab by chance? Yeah, what's up? Say that one more time.
You kind of learned it as like spin in for specificity. So like, essentially,
Yeah, who'd you learn it from? Who taught it? Colonel Johnson? Major Brown. Let me go talk to Major Brown. Because what I don't want to do is say something that conflicts with what they said. I'm going right off of what our document is and Current says, okay? So, I know where you're coming from because I used to say the same thing. That's why when I read this, I'm like, yeah, that sounds a little bit weird. But if you guys use ChatGPT, look it up right now and ask it, hey, what test gives us a better true negative or positive sensitivity or specificity? And it should say this, it should match this. Yeah, do it, I love it. If you want to look it up, you're welcome to, because I also thought the same thing. And I don't know why I thought it. I was like, isn't that backwards? But I do want to go talk to Major Brown because I had the same question. And we'll get a better answer. Okay, let's talk about HIV. This is just a visual example of some of the prevalence in the world. I'm not going to ask you a question of whether or not Greenland has HIV or not. There is two subcategories of HIV, HIV-1 and HIV-2. HIV-1 is worldwide, HIV-2 is a little bit more isolated, a little bit slower growing, harder to catch, etc. I have this up here, partly because it was left from the previous owner. I will never ask you a question on what the risk factor is of a certain scenario to catch HIV. But what can we glean from this type of information? Yeah, we can start to risk stratify our patients' possibility of contracting HIV based on our medical history interview with them. So it gives you some conversation here about sexuality and some forms of sex and the risk factor for contracting HIV. And it's pretty well known that anal intercourse tends to be a little bit higher risk for contracting HIV than not. I mean, look at those numbers, between 1 in 100 and 1 in 130. Compare that to 1 in 10,000 for insertive vaginal intercourse. That's a pretty staunch difference in the possibility of just the sheer statistical likelihood of contracting HIV. Sharing needles, really high likelihood. Sharing needles, IV drug use. I've also learned that individuals who are addicted to drugs and they use IV drugs, they tend to have a little bit lower threshold for risk. They tend to be a little bit more risk willing. They'll share needles, they're looking for that high, or they just simply can't afford to go and do it more safely, whatever that means in and so they end up in a little bit riskier situation, may end up HIV positive. You guys took med history in the freshman semester with Major McCampbell, right? Did they go over medical history was taught by Captain Lane for you guys?
Yeah.
You took the class though, right?
I took the class.
Taking a sexual history from a patient can feel very intrusive. I would recommend that you kind of practice that conversation in your head so that when you find yourself in a situation where you need a good, thorough sexual history to kind of risk stratify where your patient's at, it's not as uncomfortable and you're kind of winging it. For what it's worth, I've learned early on that eye contact, straightforward questions that have a relatively easy yes or no to them, and non-ambiguity in your questions can help a lot in that scenario. Case in point, not trying to make fun of her, it's just what happened. Asked a young lady, are you sexually active? Her response was no. I said, cool. Then she said, I just lay there. I asked the question I thought I wanted the answer to, and she answered the question she thought I was asking. So what I'm getting at is, if the information you need is value added to your decision-making process, make sure you ask the question you can get a clear response to. So there's a couple ways to do this, and I'm not, the whole point is not to learn how to take a sexual history, but because a sexual history is so important in your risk stratification for a possible HIV patient, things like, when was your last sexual relationship? Or are you currently in a sexual relationship? I mean, even that can backfire. I had one person say, I am not in a current sexual relationship. And I said, cool, when was the last time you had intercourse? And they said, last night. And I was like, what? They're like, well, I broke up with them after that. That one's on me. I asked that question. So, questions like, when was the last sexual intercourse or last sexual encounter? Do you practice insertive or receptive intercourse? Is it oral, vaginal, anal, or a mixture of those? Do you use protection? And even protection can be a little bit ambiguous, correct? If I ask the patient, do you, especially a female patient, do you use protection? They might say yes, and what they mean is an oral contraceptive pill that's protecting from pregnancy, potentially not protecting from sexually transmitted infection passage. So I recommend kind of practicing the questions that you may want to ask to help your taking a sexual history from a patient. That way when you're in the situation where it's really important to ask get a good thorough medical history, it's not quite as ambiguous. All right, I won't ever ask you questions about CDC estimates in the US. However, it's good to know because as we're interviewing our patients, if we find that our patients fall into certain categories, we might all of a sudden have our differential change. Maybe HIV goes a little bit higher, a little bit lower on our differential based on the response to those questions. Again, you guys can read that. It's reasonable information to kind of know and digest, and that's about the end of that one. Some pathophysiology, you guys learned about HIV from Major Holzberg, Dr. Holzberg, correct? All right, so really what this is kind of getting at is a description of what HIV does. HIV is really actually a very sneaky virus. It gets into the body, our body mounts an immune response, and instead of killing and or creating antibodies to what it is, the HIV finds a way to actually sneak itself into the CD4 cell. The next time that CD4 cell is needed to multiply to go fight infection, the HIV virus basically uses that immune response as a factory to produce more HIV cells. Reverse transcriptase is the kind of one of the key phrases a lot of people use. And so I sat in my microbiology class next to a really good friend of mine. We were study partners. We learned about this, and I said, HIV gets in there and it does that? That's sneaky. And she looked at me, she goes, that's sneaky, bitch. And I was like, yeah, what she said. But it's so difficult to fight this virus because it doesn't follow the rules of a normal virus. It kind of uses the host's own immune system as a shelter and a factory to produce more viruses copies down the road. What this is explaining to you, you see at the top of the little cell there, 1 attachment, 2 fusion. If you go around the room here, you see 3, 4, 5, 6, and 7. What this is describing is that there are 7 different spots where in the replication of the virus, we now have medications to attack those specific steps. And so we are doing, I say we, sorry, I am not in the lab helping with this. Somebody really smart is in the laboratory working on ways to fight the HIV virus and all of these different steps. As clinicians, we can know that exists and how to use it. All right, let's stop here. We'll start back with the HIV acute infection stage in 10 minutes.
Everything's off and it's just something else. I don't think it's typical.
They have really good protein bars on sale. There was a really good one.
Breathing. That make me wonder. You had to pick one. Subway? First you might.
Switch in my brain.
Firehouse? I don't know what that is.
And April. Like she would, so like I was planning in my like calendar. She should leave our the last week of the semester, and then I'll fly down to help her set up at my mom's house our break, and then she'll start. I'm from Miami, so she's staying with mom, and then the campus is only like without traffic, but it's like an hour and 10 minutes of traffic. Traffic's terrible. God awful. But I mean, same thing with images here, like my community. I live next to Black now. So, when I got here, that's the only place we can find like decent housing. So, I'm all the way out there. I mean, I don't care, honestly, it's not terrible. I mean, if there's traffic, like 40 minutes, but it's honestly the drive is not bad. So it's like, I mean, worse than when I was before, because I was really, I lived in Albany, so like, I could walk.
I haven't done Jersey. No, I was looking at them.
I was debating between the mask or the one you got. How big is the one you got? Like this big?
It's like the same size as the screen.
And do you just place it like on something?
Yeah, so I put it on like I have like a small bench. So so I found that at nighttime having like back, so having to like face your back, I'm sure it's like it's better to go over sleep. You're supposed to sleep. And in the morning, either facing it in your face, scalp, and like and like the energy. I'll do that in the morning and I'll go back in.
How long?
And the one that I got, there's red light therapy and so red light therapy bites beneficial for skin. But infrared is where you get like the mitochondrial.
And they're both how much? So I was also looking from the actual website. They have refurbished ones. So like 190.
The one that right now I'm trying it out. I don't like it. I don't notice anything.
Nighttime is a little more easier for me. So
Yeah, little math. I feel like well, then you're just
I was looking.
because you can do them. I feel like you can do the same type of therapy with that math.
I think with the mask they can trick deeper. But I was reading, I was looking at one that was like 300, but people were saying that they didn't. But I was researching it.
But so far I like it. Like one day.
Can't wait to go with it. Whatever's on the workout, dude. No, the one that you did. Yeah, dude. I told you. She started. Yeah, she was on her last 3 months straight up on club.
So she's moving down there.
So she'll move like the last week of Parsons. So she'll go to Jacksonville for her family live. Spend time with them first. And then I'll meet her down there. Like probably drive down during our break. I'll help her skip up my mom's house down there. And then
She's been like rereading all your
I told her, it's like sitting in the class. Like I did that too. 3 courses we gave us, like the first part. I'm like, no, you're gonna be studying your ass off. Just enjoy life until you can't. Once you enter it,
My friend said they didn't check if I did it.
yeah, so it's like, the funny is like, no one here is asking her, no one's here mentioning it. Like, I'm engaged on that. I feel like HRC and my then don't talk. The guy who was making sure, I think they didn't talk to her.
We're gonna think with Jenny. Because they let her. But then, like, the guys. I don't know. Because she's like, so like this, and like, you know, it's like, don't tell me I'm here. So I guess we'll see how it
Baby, I was like, just he comes across as being because he knows.
I know I didn't.
I've been doing medical for as long as I've been alive.
Yeah,
I would hope he knows about
right
it.
now, take
I know a lot of shit about this. What the fuck is this?
there's a time where
Oh, really?
I'm sure somebody asked him if he cares about that.
Those are really good.
All right, I want to ask you guys a question. How serious do you want this class? Are you okay with like 7 out of 10 serious?
No, zero.
No.
Somebody said 0. Split the difference, 1.5. I don't take this stuff lightly, but I do understand the grueling task at your to-do list to understand all this material. So I'll do my best to make a very digestible class for you guys. Sensitivity and specificity are one of the most annoying things to understand and then put into functional use. So let's make it real easy on us. There will be no questions about sensitivity and specificity. Now, we're going to talk about screening tests and confirmatory tests. Those are in play, but you will not need to appreciate the difference of sensitivity versus specificity to tease that out in the test question. You guys okay with that one? I'll let some specialist at some conference you go to 10 years down the road figure it out and teach you that one. Any good restaurants in town? Y'all find anything? Which one? I love Taco Bell. What? Okay. Lovers Pizza, like that's the name of the place? I came into UI one time and my friend said, "Have you been to Fogo de Chao?" I said, "No." He goes, "It costs 1 per diem." I found out that place costs 1 per diem. It's like, how much is your per diem? I was like, he said, "I don't know, but I'm pretty sure I spent all of it on Fogo de Chao." You got one? A good restaurant? I thought you were about to say something. So like any true old man, I have found the 2 restaurants in town that I like, so I just always go to them. And so usually I find that you guys are a great knowledge base of good restaurants, good food in the area, because you've done fresh research and tried new places. What's that? Umaya, all you can eat sushi restaurant in Live Oak. Oh man, I love taking my teenage boys there. I'm like, I'll tip you well, guys, I promise. But they're about to hurt you guys. It's so awesome watching them look full. My middle son just like hovers over all the other dinner plates when we eat dinner. Like, you gonna finish those 2 pieces of rice? I'm hungry. I can't afford to feed you. Umaya is really good. If you like, in my career, I've got to be a couple places that have really good sushi in the culture. And so I've become familiar with it, and Umaya is some of the best I've ever had. So if you like sushi, and you're interested in paying one price and getting a whole bunch of it, there's a couple spots in town, but Umaya is nice. There's a place called Chris Madrid's. Anybody been there or heard of that one yet? That was a little old school, very San Antonio. It's a burger joint. I think it's the best burger that I've ever had. Clearly, I've had a lot of them. But they call it a tostada burger. So it's this burger, delicious burger, with refried beans, raw onions, and tostada chips in the burger. It looks like a pound of cheddar cheese because it looks like a blanket of cheese over the entire burger. It's phenomenal. Chris Madrid's. So Chris Madrid's has a pretty cool story. Chris Madrid started the restaurant years and years ago, developed this recipe that was super popular, everybody loved it, and somebody bought his restaurant. Somebody bought his restaurant, but he didn't sell them his Chris Madrid's burger recipe, took it with him. So they did their best to recreate it, still very good. If you go to Chris Madrid's, that's what you're gonna get into. His daughter, Linda, owns a burger restaurant in town. It's a corner building, all pink, and that is Linda Madrid, who has the original Chris Madrid's burger recipe. So if you want the original Chris Madrid's burger recipe, go to Linda's. If you want the Chris Madrid's burger, which is still good, I think it's delicious, Chris Madrid's restaurant. Chris Madrid's is in central San Antonio. Previously, it had the most awkward building with the most precarious parking, and it was, you kind of a little bit took your own life into your own hands to go there, but the burger was worth it. It burned down. They bought the property next to it, set up a food truck, sold burgers out of their food truck to fund the renovation and the rebuild of the Chris Madrid's building. So then they took the property they bought for that and they turned it into a parking lot. So if you go to Chris Madrid's, the nicer, updated parking lot across the street from it is where they had their food truck parked for a long time while they were refunding their own rebuild of their building. Delicious burgers. I took my son there to eat, and like I got my burger, got his burger, and then I about to take a bite. I look up and his plate is gone, just grease on his face, just swallowing the last bite. I'm like, "You doing all right, bud?" He says, "It was so good, I forgot to put mayo on it." And I was like, pretty good statement, right? Okay, we can get into the class here. If you guys have food suggestions, please pass them along. I'm always interested. This HIV presentation lecture, it's not awkward, but it does jump from parts of the HIV process a little bit, so we'll do our best to stay pretty grounded and work through it. So we're going to talk about the acute infection first. So the acute infection looks like a very typical, very normal viral syndrome presentation. In fact, the normal, if you want to call it that, acute viral response in the human body, the otherwise healthy human body when it's exposed to HIV, looks exactly like the flu and or mononucleosis. They're very easy to confuse the two, which then of course lends us to the risk of treating them empirically, but inadvertently missing the diagnosis of HIV. So the acute infection stage, 2 to 4 weeks long. It's possible to be asymptomatic. Remember, this virus is not dangerous at the very beginning. It's just a sneaky virus that gets into the body's immune system and then uses it as its own factory to replicate. Commonly resembles mono and or flu-like symptoms, and the antibodies do not become positive for several weeks to months, which of course can decrease our ability to test if they've been exposed to it. And a lot of times those initial symptoms, that initial viral syndrome response, the fevers, chills, rigors, body aches, it will resolve without any therapy. So if we have a patient who's otherwise healthy, good, strong immune system, that got exposed to HIV, they may go undiagnosed for quite some time if they never sought care. They just kind of said, "Oh, I have a flu or whatever," stayed in their house for the weekend. So this graph kind of gives a visual representation of what we might run into. You see the red line there. The red line is the CD4 count. The CD4 cells are the big player in the immune system that gets attacked, and you'll recognize as you work through your career path as a medical provider, anytime people mention HIV, they usually talk about one of a couple things. CD4 count is always in the discussion because it gives us a good idea of the patient's current immune system status. The other one is viral load, or in other words, how many virus pieces can be detected within the body at that time. So what happens is we have a good, you see the red there at the far left, it's nice and high, good strong immune system with 0 HIV. Then the body is exposed to HIV, the HIV virus, and the HIV virus replicates like a normal virus does. The immune system, CD4 cells take a hit because that's what's supposed to happen. They're supposed to expand their ability to go fight whatever virus is in the body, and then it kind of trades places. The virus kind of goes into, it's not a dormant state, but it's just not a super high detected state because it's slowly going to spit out more virus copies of itself as the person uses their immune system throughout life. And then within time, you see that metric on the far right there, 2 to 10 years, somewhere in there. The amount of each of those in the body kind of takes place, and then the HIV virus is more prevalent in the body's own system than the actual CD4 cells. And that lower CD4 cell count makes that body more susceptible to infections and damage just because it's not as healthy as it once was. All right, so you see the two top there. Highly recommend that we know these. The HIV ELISA is the screening tool for HIV, and the Western blot is the confirmatory tool. So while I will not ask you which one is more sensitive or more specific, I might ask which one is the screening for a patient that potentially has HIV. That's important that we know that. So the HIV ELISA, usually we screen for HIV 1/2, and that's when you go to order it in your clinic. If you're going to screen for it, you'll see an HIV 1/2, and that's the screening tool. The Western blot is the confirmatory tool. So if they come back negative on their HIV ELISA, the chance of it being negative is pretty high. It's a pretty good tool. Usually don't do a test after that. If it comes back positive, it could be a false positive, so we would do the Western blot to confirm that positive was actually positive or not. These other labs are good labs that we can know to help the patient and kind of recognize how prevalent and powerful it is in that specific body. There's a CBC, the CD4 count, CD4 percentage, the HIV viral load are all tools that can be used along the way to help you in your management and evaluation of the patient. One of my preceptors found himself once, he told me the story, I thought it would ring true to kind of what we're talking about here. He had this patient that kind of was in that fever of unknown origin character. Kind of 3 to 4 weeks, kept spiking his fever, couldn't really figure it out. They were running all the tests, treating empirically. Person kept spiking the fever, right? Ran an HIV screening test, and it was negative, so they ruled out HIV. Problem was, is they ran it too late. The HIV antigen had already dipped. It wasn't going to be caught in the screening tool. They did an HIV confirmatory test just because they were looking for anything, and the antibodies had not yet gotten high enough in the body for detected. So they were testing this individual in that kind of window of time where they wasn't going to be positive on either the screening or the confirmatory test. So they kind of got to their 3rd, 4th visit, and so he said, well, I don't know what I would do. He ordered an HIV viral load, just kind of a Hail Mary shot in the dark. Let's just see what that says. And the viral load was sky high in that individual. So they were finally able to diagnose what the person was going through and such. So not telling you to do the viral load right away. A lot of times, either through just routine health screenings, we'll run HIV tests. The screening tests confirm if needed. And we really wouldn't do something like I just described unless there was a clinical indication for it. In that case, they were working through an unknown fever and trying to figure it out, and they came to that recognition. CD4 count is a great kind of predictor of the body's current immune status and ability. A higher CD4 count, the better chance that this person has to fight an infection off on their own. My apologies, guys. I got a case of laryngitis last week. I think I'm getting over it, but I can hear my voice starting to get back. And then the viral load measures the amount of the virus in the body at that time. This chart just kind of gives us a symptom prevalence in that acute HIV flare state. So look at the first 2, fever and fatigue. What does that sound like? Every single virus ever to get in anybody, right? I got a fever and I'm tired. I need to sleep this off, right? So it's relatively non-helpful, other than we can kind of tell that the body's fighting something off. And then if you even to look at the next 5 or 6 down there, pharyngitis, weight loss, myalgias. Y'all know what myalgias means? Muscle aches, muscle pain, musculoskeletal pain, kind of just, I feel like I got hit by a truck, that kind of feeling. Headache, nausea, lymphadenopathy. Which disease did I just describe with all of those? Every single one, right? And so that's why it can be potentially, I won't say easy, but possible for this acute flare of initial HIV response to slip under the radar, because it's really symptoms that just aren't super telltale for the disease. History is so helpful. All right, therapy and treatment of the acute infection. We're going to talk about therapy and treatment for chronic infection and prophylaxis. So this is talking about the acute stuff. We want to start the antiretrovirals as soon as possible. Have you guys talked about antiretrovirals yet in farm? Because we know they exist. Obviously, we have the HIV is a retrovirus. That's the whole part of it, kind of like remakes itself and spits out in the immune system. So we're talking about antiretrovirals. Start that as soon as possible. After that, again, we have somebody in that acute state. Ask them to minimize their stress, get as much rest as they could, eat nutritious food, avoid exposure to known infections, because we don't want that body to have to try to fight the HIV as well as other stuff. And of course, practice safe sex and avoid IV drug use. Super helpful. At some point in life, HIV moves from HIV into AIDS. S in the word AIDS stands for what word? Do you guys remember? Syndrome. So I've also kind of recognized that the word syndrome kind of is this like empiric, kind of this like, we kind of know what it means, but not all the way. So anytime you hear the word syndrome tacked on to any diagnosis, what they are saying is this patient fits the clinical picture of this kind of umbrella group of symptoms, and that's why we're calling that PCOS, polycystic ovarian syndrome, irritable bowel syndrome, IBS. They're this conglomerate of symptoms that match with what this condition is. And so a syndrome is not necessarily an overt diagnosis, but a cluster of known symptoms that work together to create a medical condition. So AIDS, acquired immunodeficiency syndrome, means an HIV positive patient has now been exposed to the HIV virus in their body, untreated more than likely, to the extent of the immune system has become so degraded, so damaged, that now this acquired immunodeficiency syndrome is present, and opportunistic infections that would normally not even hit us or touch us, I should say touch somebody with an immunocompetent immune system, are going to absolutely wreck that individual's body. AIDS is kind of the end stage of HIV if you want to think of it that way. AIDS, when it hits, remember, like we look at the outside of the body, but it has absolutely eroded the immune system on the inside of the body. That all types of responses to any exposures is just now almost non-existent in the AIDS patient. So very easy for them to become sick, malnourished appearing, and that's why AIDS and HIV tend to be one of those great mimickers. We can run into it at any point in its path in a patient, and it can be mimicking all kinds of different scenarios. And that electron micrograph picture there, you can see that HIV virus, that red stuff, that's just super tiny on one CD4 cells and how quickly that can replicate and get out of control. Okay, on the far right of this slide, you see this definition? I get that it's not highlighted or starred, but I highly recommend that we put that into our memory bank. How would we define AIDS? Where is that line in the sand, so to speak, for that HIV patient? Once they cross that, they now are no longer just HIV positive, they have AIDS. If somebody has a CD4 count of less than 200, and that's a very low CD4 count, that body is at risk for a lot of opportunistic infections. Or they have HIV, their CD4 count might be more than 200, but they are experiencing what they call an AIDS-defining illness, an illness that would not hit somebody quite so hard unless the person had an incredibly weakened immune system. So you may have somebody with a CD4 count of 300, but if they have esophageal candidiasis or toxoplasmosis or something like that, you would now go ahead and probably classify them in the AIDS category because they have HIV plus an AIDS-defining illness. Here are some examples of those AIDS-defining illnesses or conditions. Candidiasis, and we run into candidiasis all the time, fungal infections. Tinea, babies get thrush. People who have asthma who might be taking inhaled steroids may give some oral thrush. That does not mean that they have HIV. But when that candidiasis gets down to that esophagus, that's a place where that doesn't typically grow. And so we can kind of look at the condition and where it's at. Cryptococcus, anytime it's extrapulmonary. Cryptosporidiosis, which causes diarrhea. That diarrhea normally would be controlled really quickly with a normal healthy immune system, but in an HIV patient, or AIDS, I guess, because they have it, that diarrhea lasts for greater than 1 month. That means that body just cannot mount any type of response or response to it. CMV, HSV, Kaposi sarcoma, and I don't want to just read these to you, you guys are smart people, but these are all great examples of AIDS-defining illnesses, that once we know that we have a person or a patient who's positive for HIV, and they now have the diagnosis of one of these, they've crossed over into that AIDS threshold. If you notice, it looks like they're kind of like funny spaced out. You see 1 and 2, and then 3 is by itself, 4, 5, 6, 7 is by itself. Like those, I think the person who created this chart was trying to classify these conditions a little bit. But, so candidiasis or CMV, look, they have, they're separate, excuse me. Candidiasis, recent onset of retrosternal pain, had a history of oral candidiasis. That could be signs that candida infection has gone down to the esophagus. Retinal exam, if you do a retinal exam on an HIV positive patient and you see cotton wool spots or exudates in that retina, they may have crossed over into the AIDS. violaceous plaque-like lesions. Is derm in this semester or next? See. So violaceous or violet, what color is violet? What real simple definition of that? Purple, right? And so these individuals who on their skin get these like purple stuck on plaque type of lesions, that could be an example of Kaposi sarcoma, which typically is not present in an immunocompetent person. So an HIV person, if they get that, they probably cross over to AIDS. You can see dyspnea or breathing issues, probably pneumocystis jirovecii or Mycobacterium avium in the lungs. If you have a neurological defect in 8 and 9 there or something found on imaging, you likely have toxoplasmosis. Excuse me. And then pulmonary tuberculosis is kind of its own thing, even though it's in the lungs, it's its own thing. If we see some type of those infiltrates in the apices, and they have TB, you may have somebody who's weakened immune system can't keep that TB under control. This is not necessarily a dogmatic approach to the CD4 count. This kind of gives us some idea of how sick the individual needs to be. So you can see on the bottom there, these individuals have a CD4 count of 200 or fewer, so they're below 200, they're very weakened immune system. That candidiasis, Kaposi, or pneumocystis jirovecii, a little bit easier for them to get into that individual and cause problems. CMV, aspergillosis, needs to be under 100, typically. Toxo, Mycobacterium, and cryptosporidiosis under 50. I have seen a test question on every single one of these except for AIDS dementia. And I'm not talking about your class. I'm talking about between when I took infectious disease to CME stuff to PANREs and stuff like that and on the pants. They love asking questions about HIV and AIDS defining illnesses and CD4 counts and stuff like that. So highly recommend that you kind of earmark this as something to review and kind of understand what those AIDS defining illnesses are. Here's a picture of somebody with Kaposi sarcoma. Can you appreciate that those are just kind of like purple, a little bit lighter, a little bit darker, stuck on the skin looking lesions? Here's that same thing, Kaposi sarcoma in the oral cavity. Doesn't that just look painful to look at? Can you look past the uvula and see how it's on the posterior oropharynx wall back there? Do you appreciate that? And then if you look at the next picture, look at that. Like, I can't even imagine how much that hurts. A very immunocompromised individual, unfortunately. Here's a fundoscopic picture of somebody with cytomegalovirus and HIV. You can see all those hemorrhages, cotton wool spots, and exudates. Here's some imaging and cross-sectional imaging of the brain. And toxoplasmosis is really common. Let me rephrase. It's got a reputation for being very common in the HIV patient, creating space-occupying lesions. In other words, they actually go in and they set up shop and they maintain space in the central nervous system. So that's what we're seeing on this picture here. And so because there's something actually growing in the central nervous system, pushing on all the different nerves and spots and everything like that, these individuals also likely have focal neurologic defects as well, because the brain and the central nervous system is not transmitting messages like it needs to. I know you guys have been through some poem and radiology. What is kind of pointing here with this pneumocystis jirovecii is just look how hazy it looks. It just looks super, super fuzzy. It's kind of so infiltrated that you really can't even make out anything. It's just completely fuzzy. If you guys haven't heard about or learned about herpes zoster yet, this is an infection that is a virus. It kind of hangs out in the central nervous system. In situations of increased stress, it'll kind of flare up and travel down a dermatomal pattern from a nerve root. And so that's why you kind of see it living in a specific dermatomal type of pattern. And these, I've seen shingles so many times. It's wildly painful. I've never seen it this robust. Usually it's a pretty single line of vesicles that you kind of track down. And so for it to be this robust, that immune system is wildly compromised and it's spreading pretty robustly amongst its dermatomal pattern. Okay, monitoring and maintenance. Again, we talked about a little bit that CD4 count and the viral load can become very helpful in kind of monitoring where the body's own status is and controlling the HIV versus not. Some things that we can offer to help and or evaluate. We can do some serology for known conditions that cause problems. PPD, you guys know what that one's testing for? Tuberculosis. That's the little skin prick thing that bubbles up. STD panels, you can look at their fundus originally or refer them to an ophthalmologist for tracking if you know that they have HIV or AIDS, knowing that it gets attacked. Routine women's health exams can help prevent quicker spread of some conditions that may go a little bit more longer in an otherwise healthy person. Vaccines, wildly important in the HIV patient. They already have a weakened immune system, so if we can do something to help them fight off vaccine or infections when they are exposed to them, that's helpful. Oh look, there's something at the bottom with 4 asterisks, 2 on each side of it. That's weird, that stands out. No live vaccines if their CD4 count is under 200. That's good to know, right? Like, what do we already know about the CD4 count if it's under 200? What do we automatically classify them as? AIDS, right? Their immune system is shot. They have no ability to fight off an infection. So if we were to introduce a true live vaccine to them, like that nasal spray thing that a lot of us have to take, their body just simply may not be able to create the immune response like it needs to. So ideally, we would give them these vaccines much earlier in their prognosis before they got to that AIDS state. Treatment. Obviously, we want to treat the virus itself, and we treat it with antiretrovirals. If you have a condition that the patient is currently going through, a certain type of infection or whatever, we can treat them with some medicine to aid at the actual infection as well. And then we can kind of treat it from 2 areas now. So the therapy and the prophylaxis, we should match what we're trying to treat. This is just some examples here. So HSV or herpes simplex virus, also part of the family that causes herpes zoster, the shingles, antiviral can be very helpful. At the bottom you see cytomegalovirus, another antiviral. Toxo-mycobacterium and pneumocystis, typically treated with an antibiotic, of course on top of their antiretroviral therapy as well. Erythropoietin, you guys heard about that one in farm yet? Yeah, it kind of boosts production of blood cells. So it's going to boost production of all the blood cells, but you might get some white blood cell boost as well. That's why people might go on it. A lot of side effects with that one. If they're getting erythropoietin, we typically are not doing that from the PCM. And for the most part, patients that we're kind of describing now, these more sick individuals, they typically are not followed by a PCM. Usually they're followed by an infectious disease doctor, and probably somebody who specializes in HIV specifically. All right, the regimen that we offer them, it depends on so many different things. Anything from the pill burden, the cost, what they can afford, their resources, to side effects, their other medical conditions, allergies. That's all this slide's trying to get us at. Here are some examples of regimens. You see that in parentheses, the brand name is so much easier to remember. Unfortunately, the pants won't put anything brand name on it for us. It's all generic. So I recommend starting to put these words kind of into your studying and conversation. So we know that Biktarvy is Bictegravir. Kind of sounds like a little bit of Triumec, Genvoya, and Atripla. You guys only put brand names on the test? Do they usually do that in your tests? Pick up both? These are some of the types of antiretroviral therapies. And what you see in the far right there, that number in parentheses 372, it's kind of just talking about the step in viral reproduction that medicine is attacking. I'm not super worried about that. I'm much more interested in the fact that we just know that these antiretrovirals exist, and we kind of learn to put them into the right place. Without a doubt, prevention is best, and that prevention is a couple different ways to look at it. Ideally, an individual never getting HIV is the best way to keep their immune system intact. Right? If they get HIV, preventing them from progressing farther into AIDS and or getting opportunistic infections is ideal. Prevent them from that as much as possible. And then lastly, with the prevention status, do your best to educate your patients. Please prevent transmission of this disease. It's reasonable that you inform sexual partners that you may have this, medical healthcare providers, surgeons, stuff like that, that you've got these conditions so that they can take appropriate precautions, barrier methods, etc., to prevent transmission from it as well. We talked about this a little bit, the CD4. and the HIV viral loads, they're really helpful in kind of, again, knowing where the body's own immune system status is. Are we effective in our treatment or not? If we're going to work with antiretroviral therapy, a one-time spot measurement's not always super helpful. So if you start antiretrovirals, you get a test and it says you got 250. All right, cool, I'm glad it's above 200, but is that coming up from 200 or going down from 350? And so serial measurements can give us a better idea of how the body is responding to its current course of HIV or the response to the antiretroviral therapies. Talk a minute about occupational exposures. You guys are entering into an occupation where the risk is potentially a little higher than just some career fields, just because you are going to see people who are sick. They're going to come to you either with HIV or they potentially have contracted it, and then you're going to be evaluating for that possibility. So please take appropriate precautions to keep yourself safe. Again, leftover picture from there. I get what they're getting at. At any point, you could be exposed to some type of body fluid that is HIV in it. So please take appropriate precautions to protect yourself from being exposed to it. Healthcare personnel, we can get this a couple of ways, exposed to a couple additional ways, a percutaneous injury like a needle stick or something like that, or if a mucous membrane comes in contact with something on the right side. Obviously, those kind can carry the HIV virus in them. If it is exposed to a healthcare provider, especially the hematologic system of the blood of the provider, higher risk of them contracting that disease. When I was in phase 2, I was suturing up somebody and my glove was wet from the blood, slipped down, and the needle caught it and poked through my glove and hit my finger. Freaked out. Never wanted to suture anybody after that again. But that is an example of how easy it could be to potentially be exposed to somebody else's fluids. These feces, or you can read this, I don't agree with you. These are not typically considered infected with HIV unless they are visibly bloody. So, if you had feces with bright red blood streaks on it, maybe from hemorrhoids or something like that, you could consider that a little more high risk if it came from an HIV patient. These are some statistics to kind of give us an idea of what the risk really is if we are exposed to it. Please remember that these numbers represent known HIV exposure, not just blood exposure. So when I had the needle stick, I had to swallow some pride because I assumed I didn't want to tell somebody that I made a mistake, but they actually, the patient who I was working on was gracious enough to allow us to test his blood. Right then, no risk factors from the patient itself, but as soon as we got that patient's negative status back, everything was pretty comfortable. Still weird waiting 6 and 12 months for follow-up testing to make sure that I didn't accidentally somehow miraculously get it. Just some more statistics, guys. All right, some assessments for the risk of exposure. If you, again, this is occupational exposure, a solid needle or a superficial injury, much less risky than a solid bore needle that's got a deeper injury or was more deeper into the individual, like maybe a venipuncture or something like that. And of course, the status of the patient. If you have a HIV positive patient, but they're on antiretrovirals and their CD4 count, their viral load is wildly low, then they may not be acutely at risk for passing it on, or at least not as increased risk. So you see up at the top where it says PEP, that's post-exposure prophylaxis. And what that's describing is a scenario where somebody without HIV has a known or a higher likelihood to be exposed to HIV. Anybody watch SVU, Law & Order SVU? Yeah, like everybody does, right? Like if it's Saturday night and you run into that, you're just watching 8 episodes. There was an episode in there where Detective Sadler rescued somebody out of a bathtub full of blood. They tried to commit themselves or kill themselves, and they found out later she was HIV positive. And so there's a scene in that movie where he's like, man, these medicines are terrible. That's an example of what they're talking about. He was exposed through his occupation to the virus. He went on meds, even though he did not have any cuts on his body, to help prevent some accidental transmission of that virus into his immune system. So that's what we're talking about here. Post-exposure prophylaxis is either known exposure or an exposure that's just a little bit higher risk for it to be there or not. My pharmacy instructor, long time ago when I was sitting in class where you are, said that he had a diabetic patient bring in a plastic bag full of needles to dispose of. Don't know why a diabetic patient has a plastic bag full of needles. They should all have sharps containers. But reflexively, he just grabbed it, and all the needles were still in there. And just like sticking out. And it hit the palms of both of his hands. He was like, all I did was I dropped it, turned around, opened a bottle, and started taking the antiretrovirals. He's like, I'm not catching it today. I don't know anything about this person. It played out that didn't have it. But what I'm getting at is that's what we're talking about with post-exposure prophylaxis. This talks about some SOP stuff if you have a healthcare provider who is exposed to it. One of the things that is present at all hospitals, or should be present, is some type of a process to help providers or medical providers when they are exposed to really anything. And so really what happens if somebody is potentially exposed or known exposure to HIV, they kind of open up that policy and they kind of say, all right, here's what we're going to do. We're going to run these labs, treat with this medicine, we're going to do these follow-ups, make these referrals. And a lot of that has been evidence-based, pre-planned out. So military issues, I'm not going to ask you a military standards related to issues. The only thing I would ask is just please recognize that whatever branch you're in, they may have varying standards on who can be in the military and or stay in the military if they contract HIV, at what status they can be to do what certain jobs, meaning they might be able to stay in if they have a very specific, unique job, as long as they stay with a CD4 count above whatever. What I'm getting at is this is not something that we as medical providers need to try to figure out per patient. There are standards that help us know, occupationally speaking, what these individuals are able to do. The last thing here, pre-exposure prophylaxis. There's two medicines, Truvada and Descovy. I've seen a lot of commercials recently for Descovy. It's a little bit newer, a little bit easier on the body, not as high of a side effect profile. However, right now the evidence supports an indication only for receptive anal intercourse. So if you have somebody who is practicing receptive, like say vaginal intercourse, technically it's not approved for that, but we kind of use things when we need to anyway. What this is for is you have an HIV negative person. However, something about that person is higher risk for contracting HIV than the general public. Maybe they are a known IV drug user, or they practice anonymous high-risk sex. They might be a higher risk patient. They might go on a pre-exposure prophylaxis, so that antiretroviral is just simply living in their bloodstream, so that if they are exposed to it, it's quicker response and it can decrease their chance of doing it. Two patients that kind of always stood out to me in regards to this HIV stuff we're talking about. I was a relatively new provider, and you just saw HIV is a great mimicker, and it can look like a lot of different things. And if you have somebody with HIV, and then they complain, like a known HIV, and they complain of, yeah, I got some GERD that's a little bit worse than normal or whatever, it changes your differential. It changes what you're looking at, how aggressively you treat, etc. So I was a young PA, and there was a patient, brand new to the area, nice patient, walked in, and she's like, I'm here to talk about my headaches. I'm like, you got it, not a problem. Worked through it. She said, this is what always works for me. I have it. And I was like, you got it. About a 20-minute conversation. My hand was on the doorknob. I was ready to walk out the room. And she said, oh, by the way, I'm HIV positive. Should I also talk to somebody about that? And I was like, well, that's what your appointment should have been for. Now for your headaches. The headaches are what bothered her the most. That's what she wanted to talk about, but she also knew that if she said at the end, I would take more time. I mean, I was doing it anyway. So that would kind of surprise me, because I was like, well, now my differential changed. I'm a little bit more worried about some stuff. And we got her with an infectious disease doctor and started taking care of her. Another patient was a younger male. He came to me and he asked me to start him on Truvada because of his sexual preferences, and kind of teased it all out. He was somebody who practiced insertive anal intercourse with a condom. And so we kind of looked over and I said, look, in everything medicine, there's risks, benefits, and alternatives. Right now, you are practicing a higher sexual practice, higher risk sexual practice. But because it's insertive and you always use a condom, the chance of you contracting HIV is really low. Right? So now if we start you on medicine, you've got all this damage to your liver, your kidneys, as well as the side effects for a relatively low risk of transmission. I said, do you still want to go on it? says, it's pretty powerful medicine. And he said, yeah. He said, I know that's what I told you, but truth is at any point I could change on that and do just whatever the moment says to do. And so I went to the supervising doc and said, hey, this is where I'm at. This is what he's at. I'll be honest with you, I'm glad that he's honest with me instead of trying to kind of like not be fully transparent with me. I think this is somebody that we are at risk for. That's a duty individual. I think there's somebody we're at risk for contracting HIV if we don't offer him some pre-exposure prophylaxis. So he ended up on it. He ended up on pre-exposure prophylaxis with Truvada. Saw him every month, did a lot of lab work, make sure his kidneys and his liver stayed functioning. And for like the 2 years that he was my patient, I think it was about 2 years, he never changed his sexual practices, but he always maintained that, yes, there's a risk that it's going to change at any minute. So we continued with the benefits of the Truvada outweighing the risks at that point of potentially catching it. So just some kind of examples of that. This last year, you can read through this if you want. It's just a case study about an individual who ended up contracting HIV, who had donated plasma, sold plasma to supplement income, and ultimately ended up with HIV. Assumption would be that there was something there probably at the plasma donation station that probably exposed her to it, even though they weren't ever able to prove it. But you can read the story. That's it for today. What questions have you guys got? All right, fever of unknown origin. Fever, certain amount of days, certain temperature. Most common things being most common. We've got a couple classifications for it. Be familiar with what the definition of it is, some of the workup that's reasonable to do it, etc. HIV, we talked a little bit about the virus, the pathology, the transmission phase, acute infection, chronic infection, CD4 and viral counts, monitoring progression, some AIDS and AIDS-defined illnesses. There's probably some value-added time put in there. And then before our next lecture, at the beginning of our next lecture, I'll have some practice questions just there so we can kind of see where we're at in our understanding of it. You guys look like. Any questions? Cool. Have a great lunch, guys.